Thank you very much for showing up at pretty early morning in San Diego. Happy to have you here. We're going to have a live symposium of the Navilas OD/OS laser. My name is David Brown. I'm with Retinal Consultants of Houston and the Methodist Hospital and Baylor College of Medicine in Houston, Texas. Why another laser, especially expensive laser? Lasers are going down, you think. We're hardly doing it. We're radiologists, we're the opposable thumbs, where we look at pictures and give injections. But maybe it's not the laser, maybe it's the way we do the laser. And I'm going to show you essentially the Ferrari or Lamborghini or Aston Martin of lasers that I truly think is a better mousetrap. So anti-VEGF, there's a bunch of really good written papers on DME treatment and AMD treatment. I wrote a lot of those. Conventional laser and the DRCR protocol I failed to further improve. My hypothesis has always been that if you could really blanch microaneurysms in people with leaking microaneurysms, you would decrease VEGF drive. So we had the most patients worldwide in RISE-RIDE, and we had the most patients in VISTA, the two large phase 3 trials. And VISTA, interestingly, had no laser concomitant with the anti-VEGF. So in RISE-RIDE, you got laser essentially along with your anti-VEGF. That's the reason I couldn't get that paper in the New England Journal, because it was a combination therapy, essentially. In VISTA, we did not. So you either got laser or you got shots, and the people with shots got sham laser. And so we have not published this, but we are going to. If you look at the VISTA patients after 24 or 36 shots, they still have all the microaneurysms they started with, or they still have a lot of microaneurysms. Anti-VEGF therapy does not get rid of microaneurysms. It makes vascular permeability decrease. And so the hypothesis of a trial that we're going to talk about is that if you get rid of those microaneurysms, you may greatly decrease the amount of anti-VEGF therapy needed. So most of you in the room know about the Navilas. I'm not going to go into depth about how exactly it works, but it's an integrated retinal imaging and laser therapy with a computerized scanning delivery. But the image-guided laser is what makes it better than anything out there. So conventional laser, they conveniently put a 1950s picture with a 1950s kind of East Texas guy in there. And then the Navilas has this trim, well-dressed lady in the other laser. So what I'm going to show you is what Lloyd Clark is going to be doing for this session. The images have already been acquired in terms of taking a fluorescein angiography on the machine. But then the plan is when the physician picks out where he wants the laser. For most of us, it's the individual microaneurysms. Areas of capillary non-perfusion are often gridded. But then we go to treat, and it carries out that plan with an image track. As the patient's live, moving around, the laser tracks it along, and it's first couple times you do it, it is a little disconcerting. You're not sure whether to trust this thing. You can't see the patient as much. It's behind the laser. But the patient says, wow, that was it? Because they're used to the lens. They're used to you pressing on the eye. It's very well tolerated. And after you get comfortable that it's really going to do its job, it's an amazing way to do guided laser. So this is the plans and what you're going to see Lloyd do. So essentially, DRCR protocol I showed us that laser may not work, right? There was no benefit. The problem with the DRCR, and I was on the executive board for a long time, is it's a bunch of different sites, and laser is particularly hard to get everybody to do the same kind of laser. There's people who do ETDRS style, white burns everywhere. There are people who think laser is harmful and basically put subtherapeutic laser burns. Even those of us who think we're really good at laser, blanch microaneurysms maybe a third of the time, right? A lot of the shots are either air balls or off to the side, causing other damage. And so I thought if we had the world's best laser in a very controlled environment with investigators that are trying to do the same thing, we might see if we're going to decrease the treatment burden. And so we have a trial called TREX-DME. It's got a monthly ranibizumab arm where 30 eyes get just monthly intravitreal 0.3 ranibizumab. That's to show us the upper end of the curve. Hopefully it's going to look like Rise Ride. The TREX arm is a treat and extend arm of 60 eyes. That's the way most North American physicians treat, with multiple shots and then extend the interval. That's to see how many shots you need on average, and do you keep the same curve? That's also never been proven. And then the Gila arm, so this is a dinosaur themed thing, right? We got Gila monsters, we got dinosaurs. It's all about the marketing. And that has the treat and extend arm plus the Navilas arm. It's David Boyer in LA, my group in Houston, and Lloyd Clark's group in South Carolina. So